see. Are you able to share the screen?
Not yet, not yet.
Hmm. Hmm. Let's see. I can share the screen. Advance.
Mình
Oh, I'm sorry. Now I have fixed it. I'm sorry, Hal. You should be able to share
Okay,
now.
okay. You can see it.
Yeah, I can see it.
Very
Okay,
nice.
thank you. We can start now.
Please
Absolutely.
start.
Let's go.
Okay, thank you. Very happy to see all of you today. And today I will share some about complicated urinary tract infection in GAD. And today I share with Dr. Hung, beautiful doctor in our department. Dr. Hung, I'm very glad for very good to see you. Beautiful doctor in our department. Hi everybody, we can start now. Our presentation have three part. First part is background. Part two is some case in our department in UMC. And part three, some tip in Vietnam prevents kidney stone. Okay. UTI is responsible for an estimated 3 million ED visits per year. The patient usually come with symptoms dysuria, urinary frequency, or urgency, suprapubic pain, fever, chill, etc. UTI is also often suspected in patients with pyuria and bacteriuria who have non-specific signs of systemic unit, such as lethargy or delirium or non-localizing sepsis, especially in the elderly people in the diabetes mellitus or cirrhosis, etc. The diagnosis of acute complicated UTI is makes in patients who have consistent clinical findings with biuria and bacteriuria. UTI is unlikely if biuria is absent. Acute pyelonephritis should be suspected in a patient presenting with fever and tongue pain, even in the absence of typical symptoms of cystitis. In men, pelvic perineal pain accompany urinary symptoms such as prostatitis in men. We have some definitions, acute simple cystitis. We usually seen in the patient in outpatient clinic. I and Dr. Wee, Dr. Fong, and Dr. Jung have at the time in outpatient clinic, and sometimes we see the patients simple cystitis. But in the emergency department, we usually see the patient with acute complicated UTI. The patient usually go with symptoms, for example, fever and chill, rigor, shiverings, significant fatigue or malaise beyond baseline, or other feature of systemic illness. Flank pain, costal, vertebral angle tenderness when you examine the patient, or pelvic or perineal pain in men. And you have to emphasize some special population, such as pregnancy women, renal transplant recipient, Uh, Immunocompromising condition or poorly controlled diabetes mellitus. I think so important. And it's a time, it's kind of UTI. We have a different typical bacteria, for example, uncomplicated, UTI usually seen E. coli and Staphylococcus. And complicated UTI, we usually see E. coli with E. coli with antibiotic resistant Pseudomonas aeruginosa, Acinetobacter baumannii, Enterococcus or Staphylococcus, and partite-associated UTI and recurrent UTI, we usually see Proteus. I'm sorry. Okay, I'm sorry. We have to use antibiotics when you examine the patient with UTI, especially complicated UTIs. In severe situation or septic shock, you have to use ipilimumab or merolam plus vancomycin. In another situation, sometimes we can use ceftriaxone, piperacillin, tazobactam, or alternative levofloxacin, cipro, or quinolone. And another situation, we can use the cefepime or anti-pseudomonas carbapenem, ipilimumab, or meropenem. But in our UMC, and in our department, the rate of resistance to quinolone is so high, and the ceftriaxone is the same. So we don't usually use the ceftriaxone or levofloxacin for uncomplicated UTI. We just use in septic shock, we use ipilimumab, merolam plus vancomycin, and in another situation, the patient just only septic or not septic, not septic shock. We use ipilimumab or merolam because of the resistance to ceftriaxone or quinolone is so high in our hospital. Complication. So some complication, acute kidney injury, emphysematous UTI, renal or renal abscess or septic shock. I think septic shock is so many patients in our department every week or sometimes every day. We have a septic shock with kidney stone with UTI. And part two, we have solved three case presentations. Case one, a 50 years old female patient presented at ED with 2 days of left flank pain, nausea, vomit, dysuria, and 1 day of fever with shivering. I think, and I usually emphasize shivering is so important, so crucial symptom in our department. Other mission, severe alerts, but toxic appearance, vital sign a little bit higher, heart rate, blood pressure is normal, but the temperature is so high, 39.5 Celsius, and SpO2 a little bit low, 93 with room air. Heart and lungs exam, no significant finding. Abdominal exam reveals left flank and white blood cell and platelet is normal, but the CRP and procalcitonin is so high, more than 100 nanogram per milliliter, and a little bit lower to EGFR, 35 milliliters per minute. CO2 and CBT a little bit high, bilirubin is normal, but potassium, sodium is okay, but potassium a little bit slow. AB plus gas, decrease bicarbonate, but increase lactase. Abdominal ultrasound left hyperuretral nephrosis due to the left urethral stone. fatty liver stone at the base of the gallbladder, but not inflammation. Management in our departments. Normal saline, potassium, antibiotics, GI surgery, and urologist consultant in Management. CT scan of the patient. CT scan saw left hydroureteral nephrosis with 10 millimeter stone, 10 millimeter stone, 10 millimeter stone, and hydroureteral nephrosis, left kidney, and left peripheral, very nephric and very uritis fast training sign, gallbladder stone with the sign of inflammation. Just only 3 hours later, only 3 hours later, the patient becomes severe, mild confusion, toxic appearance, weak power, motor skin, and blood pressure is low. Blood pressure is just only 16 by 40s. 40s, SpO2 is lower. Amigat is normal, but the urine output for 5 hours, just only 15 minutes. 15 minutes. Despite you use more than 2,000 milliliters for patient. Diagnosis right now, septic shock due to urosepsis with the SOFA score 11. Left urethral stone, AKI, management noradrenaline, emergency surgical decompression, because we have to receive some patient like that, and some patients die very quickly, less than 20 hours, so we have to emphasize this patient like that. At ICU, she was treated with antibiotics, vasopressor pressure, or CRT. I will show you the results of urine culture, blood culture, E. coli. E. coli. In Vietnam, many people used to say E. coli, so a wrong pronunciation for you, E. coli. I can say you resistant, just only sensitive merobenam, amikacin, actabenam, or ibibenam. It means just only sensitive for carbapenem. And ceftriaxone, ceftriaxone resistant, and ciprofloxacin, levofloxacin, the same. At the end of our presentation, Utah and Cho Ray Hospital can share the experience about resistance of some special organism, for example, E. coli. And kidney stone is very common in emergency department. In the emergency department, the goal is to treat pain, make an accurate diagnosis, and identify and treat any complication, especially infection, because the patient die very quickly when you give some medication for the patient go home. Classic presentation, chronic pains. Some patients just only mild pain, but some patients severe pain. I remember that for 4 years ago, the doctor in our department, in our UMC, in another department, have just only kidney stone, not infected, but she have so severe, we have to use some lots of painkiller, but cannot control him. After that, we use more than 10 milligram morphine to control their to control his hand. Okay, I remember clearly because it's so special. Some patients we use this and only control handset or set a little bit of morphine, about 2 or 3 milligram, but he needs more than 10 milligram morphine to control his pain. I remember clearly. This urea, hematuria is one of the symptom we can see nausea, vomiting, a very common previous history, stone, similar prior episode, the same, many times like that. But with doctor in the emergency department have to emphasize, have to check infected symptom, fever, dysuria, urgency or frequency, or blood state to definite infection. Factor that makes storm more likely a family history, gastric bypass, certain as IV drugs, high protein diet. In Vietnam, many people usually use a high protein proteins nowadays. Prevent UTI and dehydration. Important different diagnosis. Especially some patients have a history of kidney stone, have the same pain like that, and have the fever like that. So some some situation, doctor in emergency depend on the symptom before. Sometimes you misdiagnose. For example, aortic dissection, very dangerous, or some ectopic pregnancy, very dangerous. And you have to examine and carefully, and you have to check ultrasound, blood test, or urine test. CT scan is gold standard for many considerable. It's some situation you want to know the size of kidney stone. You just only use CT scan with no contrast. But yeah, in difficult situation, you have to make CT scan with contrast to make right diagnosis and to make different diagnosis and to know how how's complication in the patient. Management. Most patients, even though with some complicated obstruction, can be managed as outpatient, but not infected. I emphasize not infected. You can go some medicine for the patient go home. The size of the size of kidney stone can help you to guess kidney stone can go out or stay there. Um, First of all, more than 10 millimeters, just only less than 20%, 20% can go out. Consideration for admission include infection, one of the important, especially in diabetes mellitus in elderly people causing syndrome, cirrhosis, kidney failure, for example, solitary or transplanted kidney, uncontrolled pain, renal failure, so that unlikely to pass. It's some situation you have to advise the patient stay in hospital. Management. We usually use a handset, especially diclofenac, to control patient pain. In some situations, I have to use opioid remains the mainstay of anesthesia. Tamsulosin. Some doctors use tamsulosin effective in some patients with larger stone, but you avoid in patients with heart failure because it can cause hypotension. The patient with evidence of obstruction or infection require emergent surgical decompression. Empiric antibiotics against E. coli and other urinary pathogens, ceftriaxone, fluoroquinolone. I think in the U.S. we can use it, but in Vietnam we cannot use it. Banning culture results indicate when there are signs of infection, either clinically or on the urinary lesion. In the patient with obstruction stone and suspected infection, they could become septic very quickly. Just five days ago on the Sunday, we have to receive the patient after the patient go to emergency department and our doctor gave us some medicine for her to go home. Just only one day later, she go emergency department with severe septic shock. Indication for emergency surgery, obstruction stores and suspected or confirmed UTI, bilateral obstruction and acute kidney injury, uni obstruction with AKI in solitary functioning kidney. We continue case 2. Case 2. A 56-year-old female patient with history of diabetes, hypertension, long-term use of traditional medicine for back pain. A lot of patients in Vietnam, especially in the south of Vietnam, usually use traditional medicine for back pain, for any pain in their body. Some situation we can see the patient as a doctor. A doctor can use traditional medicine too. Presented as ED with 10 days of left flank pain. Nausea, vomit, dysuria, but no fever. As mentioned, she wore a lot, but cussing appearance, vital signs normal, but blood pressure is a little bit low. 90/60. Heart and lung exams, no significant finding. Abdominal exam reveals left flank pain with honest mass. CT with contrast. We can see CT with contrast with a big structure below left kidney. A big structure. With contrast, we can see any blood cell and any vessel. Okay. And the Dr. Han will show you some information about this case on CT scan.
Yeah. In the CT scan, we can see that the left kidney, the enlargement of left kidney with the Detroit renal parenchyma, and also with gas and fluid collection inside the. So we can see there are lots of gas and fluid collection around the kidney. So we can see that this is a renal and perirenal access.
Okay, we continue. Urine culture, E. coli, blood culture, E. coli 2, with resistant, all of the antibiotics, for example, ciprofloxacin, levofloxacin, and meropenem, dangerous, ibuprofen, ceftazidime, okay, dangerous organism. But the sensitive trimethoprim, we can see a lot of situations, E. coli, sensitive trimethoprim. In Vietnam, as you see, you can buy any antibiotics in any drugstore, from the city to the urban or suburbs, okay. But trimethoprim, pharmacists don't sell trimethoprim for you because they think it can make the patient allergic. So it's a reason why we can see a lot of situations. E. coli is sensitive trimethoprim, but a Cipro or Levo or any medicine you can buy any drugstore in Vietnam. And bus culture, the same E. coli is sensitive meropenem and amikacin cefepime. Emphysematous UTI, infection of the lower or upper urinary tract associated with gas formation, may involve the bladder, renal, pelvic, or kidney. diabetes mellitus or proximal major risk factor, and cirrhosis and Cushing syndrome or elderly people are major risk factor. Most patients complain of dysuria, fever, chill, flanks, or abdominal pain, nausea, and vomiting. The onset of symptoms may be abrupt or evolve slowly over 2 or 3 weeks. E. coli or Klebsiella pneumonia account for 65 to 100%. Other reported Proteus, Anthracoccus pseudomonas. CT scan refers imaging modalities because it is more sensitive than other modalities and can show you the extent of gas formation and any obstruction in the urinary tract. Some complications you can see: acute kidney injury, bacteriomy, septic shock, or pneumomedium stena. We have a case, pneumomedium stena, and I think in the near future, Dr. Hong will show you that case, our case. You can and the patient died very quickly. Case 3.
Dr. Howe, I have a question about that case.
Yes.
That's fascinating. I've never seen emphysematous kidney infection or pyelonephritis. Was that patient immunocompromised?
Not compromised.
No.
You saw the pneumonia mediastina?
Mm-hmm.
Or
no, I want to know if
this patient, okay.
Case
this
2,
patient,
yes.
Yeah.
She has diabetes.
Diabetes. Okay.
Cushing
syndrome.
Wow. Okay.
Cushing syndrome. I think Cushing syndrome.
Wow.
Because I usually emphasize the doctor in our department have to pay attention so much about this case, about the same case with Cushing syndrome, diabetes, or cirrhosis is so important because it's based on diabetic quickly. Because,
such a good case.
Yeah, because when the patient comes our department, they have to use some lots of medicine in the drugstore. So the symptom is the symptom you can see clearly, but the situation so severe. So I usually emphasize all doctors in our department have to pay attention too much about the same case.
Yeah. Thank you for that. That was really, really great case.
Because the director usually call me, why the patient died weekly? Why the patient died weekly?
You're in
so
trouble.
I have to pay attention about the same case like that. Okay, we can continue case 3. 37 years old male patient with history of diabetes. Presented at another hospital with 2 days of dysuria, urinary distension, perineal pain, and fever. He was diagnosed with urinary tract infection, neurogenic bladder suspected. Just suspected. His treatment was IV antibiotics for 5 days, and then discharged with oral antibiotics. He reported that fever is lower than normal, becomes normal, but dysuria and a perineal pain persisted, and it revision come to emergency department. Admission he was alert. Vital signs you see, okay, it's normal with room air. Lab stat, white blood cell a little bit higher. GFR is normal, but CRP so high, CRP so high for sorry, and procalcitonin is normal. Procalcitonin is normal. Abdominal ultrasound show us about the process volume is very large than normal, with more than 50 millimeters, Please dimension with with heterogeneous echo. A little patient in our department, and I think in many emergency department. Doctor don't usually examine the patient like this. Primary diagnosis, the first time come out department of process plan access, management IV fluids, broad spectrum antibiotics, when urine and blood culture result. CT scan with contrast. Dr. Han, we saw many people the information of CT scan.
Yeah. So in this CT scan, you can see that there is the post test gland enlarged, and you can see there are many abscesses here. So this is the image in a coronal view, and this one in a sagittal view, you can see that the prostate abscess here in here.
Okay, we can continue. Urine culture negative, but blood culture is staphylococcus aureus. Am I right? I think the urine culture is negative because he used to use some many antibiotics before, and staphylococcus with chemotherapy reason he pharmacist didn't sell chemotherapy, so chemotherapy is sensitive for all organisms in Vietnam. But it's a lucky, it's sensitive linezolide, streptomycin, resistant clindamycin, penicillin, erythromycin, oxacillin. And pathogen is necrotic tissue, not cancer. Lucky, so lucky. Acute bacterial prostatitis incident from 20 to 40. I'm not ashamed to prostatitis because more than 40. How about you, Max?
I am 40 this year, so I still am at risk.
Just only 6 months. 6 months
That's
later.
right. That's right.
That's right. Common pathogen, E. coli, Proteus, and other Enterobacter, Pseudomonas. Okay. Acute bacterial prostatitis can be suspected based on the history and physical exam. And the patient appear ill with systemic symptoms of fever, chills, malaise, dysuria, and pelvic or baridial pain. Rectal exam, many teacher when I learned in medical school obligates many students have to rectal exam when you think about prostatitis, a swollen and painful prostate, labs evaluation, ultrasound abdomen and culture. Sometimes STI testing are warranted if the patient is at risk. Blood culture are not typically needed unless they are concerned for sepsis or the development of endocarditis. Radiographic evaluation or CT scan in some situations. Okay, some reference. Think about 10 years ago. Mark, where are you?
In the very far back and need a haircut.
10 years ago. 10 years ago.
Wow, 10
Many
years
people
ago.
look so young. Many people look so young.
All of
and
them.
Mark,
Look at
handsome.
do not lie.
2 years ago. Remember the time. And the tip
So much
and
fun.
part three in our presentation tip in Vietnam. can prevent kidney stone. Kidney stone. Drink a lot of beer. Okay. You don't need to go emergency department to treat kidney stone. It's time. It's time, Mark. When you come back to Vietnam?
September.
September. Okay.
So
September.
good.
So good. Good time for everybody
So much
to
fun.
together.
So much time.
Okay, our presentation is now finished. Please share some idea and some experience from your country and Cho Ray Hospital for our department, for our member in UMC to learn more. Thank you so much.
Thank you.
Yeah.
Thank you, Dr. Howe and your UMC team. That was a great presentation, and I learned a lot about emphysematous pyelonephritis. I've never seen that. I probably have missed it in my history. I have something to share at the University of Utah. I have been frustrated recently because our urology team, when patients have a kidney stone that is infected, refuse to operate to take it out.
Yeah.
And instead insist that I admit the patient to the internal medicine team until the urine is sterile. And that is different than what I was taught in medical school and residency. And I don't think the literature supports that. Has anyone had that problem at Cho Ray or UMC?
Some situation in our UMC, the patient denied operation, just only want to control their pain, and after that they want to take some medicine to go home. But in some severe situations, especially in a special population, for example, causing symptom diabetes mellitus uncontrolled, and kidney failure, heart failure. Okay, in that situation, especially elderly people with diabetes mellitus. We usually advise the patient, but the patient will be denied to operate or denied to go to hospital after you give the patient some painkiller. But after that, after 1 day or 2 days later, when the patient fever, the patient has fever with rigor or shivering, they usually go to emergency department and go to hospital, and they usually accept many advice after that. It's in UMC, in Cho Ray, Dr. Đại.
We have the same situation. Sometimes surgeons don't want to take it out very fast. They say that they need antibiotic for a while, maybe 5 days, and then after that they put the double J to to reduce the pressure. And mostly they come to the abscess, the kidney abscess, and sometimes with the normal like very very strong antibiotic, and it'd be better. And after everything is ready, they take the double G out, and after that they just remove the stone. After that, they say that if the patient go with the severe condition like sepsis or septic shock, you cannot operate it.
Yeah.
When you operate it, it's worse. So they need to operate it. Right? So just give them antibiotic, very strong one, blood counter, urine counter, and wait for result. And for maybe a week. And luckily, they just put the double GA on 1 or 2 days to make the for blocking the urine, and everything will be better. As so many cases here, especially when you have the sepsis from the kidney, it's very fast. People get worse very fast, and they will die very quickly if you don't do anything. So if you think about the UTI, the complicated UTI, antibiotic is very important, and you as soon as you can give them, they can get better.
I'm glad to see that you all have the same frustration with me. I think surgeons should be taught source control will help infection, uh, like necrotizing fasciitis or abscess or appendicitis. And my urology colleagues oftentimes refuse to take the patient to the OR, which is a source of frustration for me. So this is a very good presentation. Thank you all for putting it together. Is there anyone else who has anything to share? Thank you, Dr. Howe.
But let's look later. But Dr. Howe, you prepare so well. Be a good lecturer, you know. Do PhD and be the professor, Dr. Howe.
Yeah. Yeah, thank you.
All right. Dr. Howe will happy anything and happy to collect some case for me. Yeah.
Thank you so much.
Thank you so much today.
September, you will be in Ho Chi Minh City for how many days, Matt?
Probably two days, Dai. Yeah, and then to VSEM, VSEM. So
I didn't receive any information for that until now. I didn't receive information.
Yeah, Dr. Son and his colleagues at Bach Mai are very slow to publish any. It's very frustrating for me, but my hope is that ASEP will push to have this published very soon, and in the next week, you all should be getting some information about it. It will be September 28th through 31, 28 through 31 in Halong Bay. So it would be very nice. I've asked Dr. Son to request lecturers from Cho Ray and UMC. So if you all are interested in lecturing or participating in VSEM, that would be excellent to get you all as lecturers.
You have to arrange the time we meet together, Cho Ray Hospital, and
of course,
UMC. It's a prevent you prevent kidney stones. Okay?
Kidney stones. Excellent. Yeah, we can do this. Yes, lots of beer.
Yeah, okay.
It'll be perfect.
Yeah.
most excellent. That sounds great.
Yeah.
Yeah. Well, thank you everyone for this opportunity. For those of you who are able to stick around, there are some questions about emergency medicine training that I was hoping to ask, and I would love to gather some responses. So, are you all willing to stick around for a little bit? And
okay. Minute after now, the common news.
Great.
Ready.
Great. So I'm going to. I will show you the first question I have.
Yeah.
And you all can answer as you would like. So the first question is, what, if any, specialty training did you receive before you began your full-time practice in emergency medicine? And so this is supposed to be a discussion. So if you all want to just let me know what you think, go ahead and say, did you have a combined residency where you did toxicology, critical care, emergency medicine? Did you do our diploma in emergency medicine? Did you train somewhere else? Did you have other training? And I'm happy to hear. Dr. Howe, do you want to start? Oh, you're muted, Dr. Howe.
Okay. When I graduated university 13 years ago.
Recording in progress.
Okay. I want to be a resident doctor in geriatric for 4 years. For 4 years. After that, I applied in UMC. I applied to UMC, and the director want me to follow emergency department because it's the first time. Because it's the first time our department our department don't have our department that time don't have didn't have any doctor. So when I work in emergency environment, I like it, but I follow them. I follow them. I follow them about more than 15 years until now. And when we learn in the when I learned in the university, I just only a little bit more than 1 month, to learn about emergency. And when I was resident doctor, I have a 6 month. I have a 6 month training in Thống Nhất Hospital and Cho Ray Hospital. Cho Ray Hospital for 6 months. For 6 months for 6 months about emergency. Yeah, about emergency. After that, we learned about we learned about cardiology. We have about 6 months, 6 months to learn about emergency too. Yes. Finish, Mark.
That's very good. Thank you. Yeah.
Thank you.
Anyone else? Dr. Dai?
Well, before I'm be an emergency doctor, I'm just a graduate student. And they put me to the emergency department, and I just worked there for 15 years. So mostly we don't have specialized like toxicology, critical care, emergency medicine when I was young. So I just left the school, and they have position on Ray, and I just go into emergency medicine, emergency department, and work there for many years. All right.
You learned on the job.
Right. Just like a job. I think that's more just apply for a job. Just like Dr. Hao, we need a job. So the hospital need somebody to take care about emergency. And they just, let you in and train you like emergency. But before that, before we have the program like toxicology, critical care, emergency medicine, like Dr. Thao, we just like the older will care about the younger, like the senior will share hand by hand to the junior, and it's not good because you don't know exactly what's the bad thing you can do for the patient. So after the how I have the faculty for emergency for critical care. We are applying for specialist grade 1 and specialist grade 2 for that specialty. And they care about critical care and also emergency medicine. And you come, Dr. Mark, you come and you give us a diploma of emergency medicine. That's a good thing, the good idea that everybody can join and to know how American doctor can do or should do or clinical pathway that you're doing, and it helped us a lot to work like American, work like international guideline. That's the point. So I think that most of the people here don't they don't think that they will go into emergency for the first time, but position for emergency medicine or emergency department, and they just go in there and practice it, and they will be trained when they work. That's the point here.
Yeah, that's a great answer. Thank you, Dr. Dai. How about you, Dr. Wee? What was your experience?
After I graduate as a doctor, I come to Tract hospitals for work. Work for about 2 years. And I have no specific training before I began my full-time practice emergency medicine. So I come to Tract hospitals many doctors, the doctor specialists, rotates in the emergency, guide me how to do, what to do. And some doctors older than me, like Dr. Dai, or some doctors older, guide me what to do about. But I have no specific training about emergency department, about emergency medicine. So I learned, and so I have some strong decisions.
Right.
And I have the 15 years practice in the emergency medicine. So I interest about diploma in emergency medicine. I realize it is very necessary for all the doctors to increase the knowledge and practice skills and confidence to treat the patient.
Thank you.
Yes, I hope in the future, UMCs and Cho Ray hospitals and you can cooperate to establish the unified program to treat the doctor graduates about the emergency medicine.
Yeah, great. Which you thought?
I like this idea. That's a good answer. Are any of the younger doctors who are there today, have anyone trained in another country, or has anyone been to just a specific emergency medicine residency? Anyone listening tonight, or is everyone's circumstance very similar?
Maybe it's the doctors graduates after 18 months. 18 months.
So some of the people, some of you who have graduated from the diploma program.
Yes, and some doctors in other hospitals, they want to establish emergency department. They can send the doctor to Cho Ray Hospital, UMCs, and we have the unified program to train the doctors about the emergency medicine.
I would like this. That it brings me to my next question. Do you think there are certain limitations or barriers to young physicians who want to consider a career in emergency medicine? What things prevent a graduating medical student from going into emergency medicine?
You always, the main reasons that prevent young physicians from considering a career in emergency medicine, like you also list here that training opportunity. Yeah, so as Dr. Hao or Dr. Lee, Dr. Dai said before, then all of us mostly graduate from med school, and we have like postgraduate training in some specialty, but not emergency medicine. We don't have program like that in Vietnam, and I think that is the main reason. That is the first reason, and the second one is the hectic schedule. So the ED is always busy and crowded, and it's a very stressful environment. So we have to the schedule is very hectic, and it's a very demanding job that many doctors if they don't have like big love for emergency medicine, they may give up, or they won't considering enter the ED. And other, I think there is one reason you list here is quite important, is that the respect among other medical specialties. But I think this one has to be changed, because emergency medicine is very very special. It's a very challenging but also rewarding specialty, we deserve to receive more respect from other specialties. Is it not a place for disposition patients, but the ED is the place for to save people, to save people who are somewhere between life and death. And so in the ED we can do a lot to save the patients. And I think if we can develop emergency medicine more, then we will receive more like recognition from other specialties, and it can attract more young doctors to join the ED.
That's a very good answer. How do the rest of you feel? Are there other limitations that you feel prevent young medical students from thinking about emergency medicine as a career? Is it hard to make a living in emergency medicine? Is it really difficult to have a clinic and work emergency medicine?
I think
I know some.
Yeah.
Go ahead.
I think the young physicians after graduate, they have not confidence to treat the patient because they have no training opportunities. So I think the doctors after graduate, they have the training about emergency department like the program. They confident to treat the patient. And the second reason is the most recently the economic and financial poverty. So it's low income, hard work. So we cannot keep the doctor to continue in the emergency department to develop. This is the difficult in Cho Ray hospitals. They cannot keep the doctor in emergency department.
Yeah, it's a difficult.
Dr. Dai have idea about this, Dr. Dai?
Yes. I'm sorry that I missed something.
No, that's okay, Dai. We're talking about this second question. Are there things that you think prevent young medical students from seeking a career in emergency medicine or considering emergency medicine as a job?
And I thought about that. I thought about the young physicians have the low income or hard work, and we cannot keep the doctor in the emergency department to develop.
All right. So the point I told many times before that we have three things for one doctor can develop their career. One of them will be income. So if they have something like the income is not good right now, nobody can love to go to the emergency medicine. I've been I taught the conference from Asia emergency medicine for 8 years before, when all of the round table like this, and they just asked the same question: what's happened to the young doctor? Why they don't want to be emergency doctor? They just told me that because of the hour of working is so hard, and the pressure of working is so hard, and the income is not good. So three of them make the young doctor, they don't want to go into the dangerous area, just like emergency room or emergency department. They just read about the suing. They read about something like abusing, something like attacking in emergency, and the people going die very quickly. It's so stressful. So when they go to the stressful place, they go to the very dangerous place, but very low income. So they don't want to be emergency doctor. So that's the point. I think that income is the most of barrier when you go to be an emergency medicine around Asia too, not in Vietnam anymore, but around Asia.
Around Asia.
Right. That's the point. And for for studying, I think that because you spend a lot of time in emergency, you don't have any time for your family. You don't have any time for developing your knowledge, like working, researching something like what your hobby want to be. So that's the period that they just practice for emergency for a month or 2 months, and after that, few of them want to be stay in emergency. Only one, or only the people think that emergency very interesting, that you always meet a new patient every day. So they know that it's very challenging, interesting every day with new patient, every day with new things. So they love that. Most of them they don't care about that because it's so dangerous and so stressful, and income so low. That's the point. I think so.
Yeah. Thanks, Dai. That's a good insight for me.
Dr. Matt, I want to share some one place.
Please.
In my point of view, about emergency doctor. As you know, the salary in Vietnam is so low in the same any specialist. But when you become a cardiologist or any specialist, you have a lot of patient know you, a lot of patient know you, and after that, working in hospital, you have a time in the afternoon after finish everything in the hospital, you can have a private outpatient clinic, and it's a big income for doctor. But in our department, in our emergency department, doctor can know you, they
Impossible.
know you, yeah, they just know you. So if you open or manage private outpatient clinic, a little patient come with you, and you have a little bit income, because in Vietnam, income of the doctor the income doctor from the hospital is very low. So income in outpatient clinic, private clinic is so big, more than 10 or even 100 times in in hospital. So it's a
In hospital
reason,
salary.
yeah, a reason a lot of doctor don't want to follow emergency department. Yeah,
That's really
yeah,
important information for me to
yeah,
understand how, and brings me to
yeah.
another question.